Welcome everyone to the Medicare Secondary Payer or MSP Physical Intermediary Standard System or FIS claims webinar. I'm Tom Ryan, I'll be your presenter, and today I'm joined by Karen Curtis from my team. She's going to help with technical problems. She's going to go ahead and put some information in the chat for you, but also read some questions in the chat should they arise. She may give you some answers or other types of links to help you out. One of the things I want to point out about the Physical Intermediary Standard or Shared System, again, FIS, this is for those of you that bill on a UB04 paper claim form or an 837I electronic transactional claim. We did have some people register for us for this webinar that bill on a 1500 claim form or an 837P electronic transactional claim. Those two types of claims are not being addressed at all. This information may or may not pertain to you. I do recommend that if you bill on the 1500 or the 837P, you register for the October 2nd webinar, which is on the multi-carrier system claims. The multi-carrier system handles those, while this one only handles the UB04 paper claim form and 837I. This one being the Physical Intermediary Standard System, or FIS. A little bit of housekeeping. If you would like the presentation for today, it is available for you to download right now. You can go to the training center to do that. The training center is on our website. It's wpsgha.com. At the top, you'll go to the middle, and it's called Training Center. Underneath there, in the body, there are 9 boxes. The first box in the upper left corner is Live Events. That's where you'll head to for training material for today. I will let you know that the PowerPoint will be removed either maybe later today or tomorrow morning, just depends. What we will do is post it back to the website in the second box. That is the Encore presentations box, and that'll be done probably within the next couple of weeks. It'll be available for 60 to 90 days. If you have any questions at all, please put them in the chat. We'll get to them. We'll address them later. After this event, we will ask you to take a survey and also send in any follow-up questions that you have. The survey will be a link given to you either in the chat, the follow-up email, or a variety of other sources, so we'll get to that. A little bit of a disclaimer. This information is for educational purposes only. The reason that we put that out there is because Medicare changes often. And how many of you have ever been through that where you're like, oh, I just learned this and then it changed. So we want to remind everyone that while the information is accurate as of today, it may not be tomorrow. So make sure that you're aware of the rules and regulations. They are available on the CMS website, and that is your best source. I will show you a little bit of information on there. Also, there were some questions asked pre-submitted, and those are great. I will definitely get to those, but I want to remind everybody I can only answer those as best I can based on the information you gave. Some of you did put some different pre-submitted questions in, and I will ask that you give I will give you a base answer and then prompt you to add more information to the chat should you want a further answer or further clarification. So what's our objective today? For the person that kind of jokingly said it's obviously that MSP is there to annoy you, our objective is to take that annoyance away and clear it all up today. No, I'm kind of joking with you a little bit there. Medicare secondary payer claims are a big area. There's a lot to cover within it. What we will do is talk about some of the coding that the claim system expects today and information you need to get those claims submitted. It's not necessarily about what is primary payer, what is an employer-based plan versus a non-employer-based plan, those types of things. This is more about getting the coding onto the claim and how to get that in. So with that said, we will look at claim submission, we will look at billing information, and we will do some question and answers to get through all of this information and to wrap us all up today. So claim submission comes first. This covers some of the general billing information. Now, the reason that we did this is because we did have some general questions come in, and by that I mean they were submitted in the chat. So I don't want to leave any of the general questions unanswered. I'll try to point out slides that were built for general questions and kind of help you get through some of those pieces of information. So first of all, the first question that we actually did is, do I need to file electronically or can I file on paper? This is 2 slides built in, but the actual answer is yes, you should be billing electronically if possible. And I'll explain a little bit more. The Administrative Simplification and Compliance Act does not make Medicare Secondary Payer an exception, unless you are the third payer, which Medicare would have 2 primaries, then there is an exception. Okay, so what we look at when we look at that regulation is that there is a list of exceptions. They are available in the CMS Internet Only manuals. In particular, it's the Medicare Claims Processing Manual, and they're in sections, chapter 24, sections 90 to 90.6. Please take a look at those if you're looking for those exceptions. The reason that I'm not going to list them all out is because it is not an exception for Medicare secondary payer. And yes, you are required. Again, the issue is what happens when Medicare is the tertiary payer, third or more payer. So yes, that does happen. We understand that. And that is one of the situations where it can't always be accepted. So you are allowed to send a paper claim. Okay. Um, a few people did ask us what happens if there's two primary payers, which one does Medicare expect to see first and second? That's not Medicare's decision. That's actually a state law. The state law will establish who pays first and second. I do want to point out that one of the ways this does actually happen, and quite frequently for Medicare, is when there is a car accident or an accident, and the person also has an employer-based plan under their spouse. This means that Medicare would actually be the third payer. And so we don't tell you if the car accident or the employer-based plan has to pay first. Instead, the state law does that. What Medicare does state is that we do need both pieces of information. So hopefully that all makes sense. With that said, let's move on to those paper-based. You can submit claims under the NASCA waiver, and we understand that. Somebody asked if they needed to submit the red and white, and the answer is yes. The UB04, I know mine kind of looks a little orange in the picture, but it does need to be that basic claim form, and yes, you need to submit on that. When you do that, you do need to incorporate all of the correct information, and you do need to send that to our claims department. Okay? Again, if you want that instructions, I do recommend that you take a look at the information for billing paper claims. Okay, so when we say red and white form, remember it's the original one. We're always going to recommend including a remittance device with it. Just that's a recommendation. If you have all the information on the claim, it should go through just fine. If you would like more information on where to send it, go ahead and look at our website, and you can go under contacts, it'll get that. Now, if you say I have to file all of my MSP claims whenever there's one or more primary payers on paper, then you do have to ask for an exception under the ASCA administration. And they're going to ask, why do you need to file all of them? Why can't you file those electronically? And if the reason for that is that your system right now doesn't allow it, and you say, oh, there's no fix in place and we don't really ever anticipate being able to do that, the Administrative Simplification Compliance Act will probably not allow you an exception for that. If on the other hand you say, our system isn't allowing it right now, our vendor anticipates having this fixed in 6 months, 3 months, 90 days, whatever the situation is, then they'll probably allow it for that period of time. So hopefully that addresses all of those questions on the paper claims and some of the exceptions and things that came up. There was quite a few in there actually. I was asked, is there basic claim processing instructions? And the answer is absolutely. If you're filling out the basic claims processing instructions, we always recommend looking at the UB04 instructions available in the Internet Only manual. That's the reference that's on this slide. But it really does talk about, hey, do you have the patient information, the provider information, data service procedure code, diagnosis code, revenue code? I mean, those really basic things. I will tell you, they don't change just because someone has a primary payer. Now, an occurrence code or a span code, there are other codes that will change, and we do know that. So when we talk about the basic requirements, those are the things that don't change. One of the questions I did get is, for an RHC, what's different? I'm not really sure what you mean on that, but here's my basic answer. Your basic requirements never change for an RHC. They are what they are. If they have Medicare Secondary Payer, you're going to follow along, and we're going to talk about some of the things you have to code to make sure are on the claim. But it's not different than any other payer. It's not different than any other type of claim, whether it's an inpatient or outpatient hospital, critical access hospital. It doesn't make a difference. Medicare Secondary Payer is a universal program across the board. Okay. So hopefully that answers that. You can apply that to critical access hospital. You can apply that to RHC, FQHC, all of it. Medicare Secondary Payer is a universal program. Next, I would like to move a little bit more into billing information. Now, this is going to be some of your basic billing information. What we've done is also looked at some of the denials that we see and what's happening with those denials, or what's causing something maybe to put an extra insurance on file. And that's where a lot of this information comes from. Okay. So let's start with employer-based plans. On the claim, you do have to code the type of plan. What is the primary insurance? Is it employer-based or not employer-based? There are three types of employer-based plans. They are A, B, and G. A, they are working aged, which means the insurance is through a working aged person. However, the Medicare recipient is age 65 and older, and they do have an employer group health plan. It also indicates that that employer group health plan has 20 or more full-time equivalent employees on that plan. That's what that is coded to mean. A B is an end-stage renal disease with an employer group health plan, and it is in the coordination period. Now, the reason that the B states the coordination period is that during the first 30 months, regardless of the number of employees or anything else, if they have end-stage renal disease, Medicare is secondary to the employer group health plan. After that 30 months passes, Medicare is primary. So that's why there's a B, but not like something saying, hey, it's past the coordination period, we still have this other plan primary. It doesn't work that way with renal dialysis or end-stage renal disease eligibility for Medicare. And the last one is G, which is disabled but under 65 on a large group health plan. So it's very, very similar to A, except the patient's age for Medicare is under 65. They do have a disability, and the plan has 100 or more, which is why it's called a large group health plan versus an employer group health plan, which is 20 or more. So age and size of plan. If this is not coded correctly, this can cause issues in the system, i.e. we can add a second insurance even though it's the exact same one, even though it's the exact same insurance, and then stop all claims from processing. Not just yours, but all claims from processing. Okay. With that said, there are additional plan types that you can code for primary payer codes, and they are the non-employer based plans. So is it a no fault by state definition, a workers' comp by state definition, W, which would be a workers' comp set aside. So there's already been a legal action taken. There was a finding, yes, it is a workers' comp case. There's this amount of money to continue to pay after this legal case. That's a set aside amount. Is it a public health service research grant? Is it a federal black lung program or liability insurance? And those are the codings for those. I was very specifically asked for what is the primary correct code for the VA. I'm going to assume you mean in terms of the payer code for the VA, and in terms of Medicare primary secondary insurance, there is no payer code for the VA. There's the VA doesn't pay, in which case Medicare pays, or the VA does pay, in which case Medicare does not pay. But it's not a primary secondary situation, so I don't know what code you're exactly looking for, but in this class we won't talk about it because it's not Medicare secondary payer. There is also some condition codes that need to be reported on the claim in certain times. So that's why it says report applicable. Not always do we require a condition code, but condition code 02 is reported when the patient's conditions, illness or injury, is employment related. So you would report this as a workers' comp MSP claim. Yes, it could be a set aside amount. So there was two different ones, if you remember correctly, that this would work with. 06 is reported when your patient with Medicare-based ESRD has an employer group health plan and is in the 30-month of entitlements. So that's that first 30-month, that coordination period that I talked about, where they get 30 months where Medicare is secondary, and then after that, it's Medicare primary. 06 is just to indicate that they're within that entitlement, that coordination period. And you do have 77. This one is quite literally reported to say the primary paid it in full and there's no patient liability. This does not mean that you should not send this claim in. It's actually the opposite. You should still send this claim in. report condition code 77 when you have also a contractual agreement with the primary to receive a certain amount as payment in full, and you receive that amount. So you may say, we billed this amount, contractually we're obligated to accept this amount. That is our condition code 77 because that's all we can get. That was our contractual obligation. Okay. Um, so it's a variety of situations with that one. Also, let's say that you have a situation where there's no contractual agreement, a contractual obligation agreement, but you've been paid and your charges are paid in full. Again, that's paid in full. You would want to report condition code 77 here. So condition code 77 indicates to Medicare that there's no liability. There really isn't anything for us to pay. It doesn't mean it's not covered. It doesn't mean we couldn't apply deductible to the Medicare deductible. It doesn't mean that we can't look at other things such as the benefit period and other things like that. We can do all of those different things. Okay. One of the questions that we got is, do you need a condition code on every claim? And as this one says, report applicable. In other words, no, you don't need it on every claim, but you do need it when there needs to be one there. So when these situations apply, you absolutely need the condition code. If they don't apply, what are you trying to report a condition code with? And that becomes another issue that'll RTP because we're like, I don't know what this condition code does, right? So I want to make sure we have that done. All right, just as a scenario, Medicare covered charges are $5,000. You expected from the primary payer $4,000 and received all $4,000. On the MSP claim, you report charges as 5. You will report value code, and that's the code that we talked about with a couple of other things we haven't quite got there yet, but it'll tell us a couple of things from their employer group health plan with the 4,000, and you would report condition code 77. This tells us that this $4,000 is your contractual obligation amount. Okay, your contractual obligation amount. So it's there. You're not going to get anything more than that. So when we talk about these value codes and we give an underscore, that's because we're going to talk about those next. So I just want to make sure that you're aware of what we're talking about here. So there are certain value codes that you also must report. With the amount received from the primary towards the Medicare covered services on a claim. Value codes are required when there is a payment. So value code will help us understand what's going on, who paid what. An inappropriately applied value code can cause other issues in the system. Again, it can cause an RTP. It can cause us to add something and have to do an investigation. So you want to be very careful with these value codes that we're first going to go through, okay? So a couple of things with value codes, just to remind everyone, is that they are 12 for working aged over 65. We talked about that one. That's the employer group health plan. 13 for end stage renal disease with an employer group health plan. And then 43 for disabled under 65 with that large group health plan. And by making sure you have the right value code, it will help us get through everything, especially if it's a 43 or a 13, 43 or a 13, okay? Oops, and guess who forgot to advance the slide, so I will apologize for that. That was my fault. But non-group health plans, 14 auto, which could be an auto. I'm sorry, no fault, which could be an auto. Now, the reason we say that is some states have what's called liability insurance for auto and others have no fault. So it really does depend on the individual state. We don't have like a choice in that option and really go back to the state and figure out what they have. So it's just something that makes sense to people. Hopefully, really, what is your state defining your auto insurance? So it's they're going to be a 14 or it could be a 47. Workers' compensation, again, is this a state defined workers' compensation benefit and is workers' comp going to pay? Then we got 15. Again, the public health, the research grants, that's 16. Federal black lung, 41. Somebody asked where workers' compensation set aside amounts belong. Let me rephrase that or say that again. Workers' compensation set aside amounts. 15. They're still workers' compensation. Just because they're a set aside amount doesn't change the fact that they were from a workers' compensation case. So hopefully that does make sense to everyone, just as we kind of work through some of those different items there. We were asked in particular about value code 44, so we do want to address value code 44. Value code 44. Primary payer's payment is less than the amount you were expecting. That's the key to value code 44. We got less than we thought we're going to. So we have a contractual agreement, but for whatever reason they paid us less than. So okay, report with the OTAF amount. Obligated to accept as payment in full amount is what that is. And it could be less, right? The actual payment can be less than that. And that's what you're obligated to accept. You're putting this value code on there. The primary paid you agreed to accept as payment. So working age, Medicare covers 5,000. You expected 3,500. You received 3,000 because 500 went to deductible. How would you code that? How would you code that? Well, you you would report the the value code 44 with this 500. This is what went to deduct. It's what you expected, but you didn't get because it went to deductible. Please don't report value code 44 and the obligated to accept his payment in full. It doesn't make sense to the system. The system doesn't like that. So when you go to report the value code 44, you would, again, report the amount that you expected. So again, here, what did you guys expect? 3,500. Sorry, I said it backwards. You expected 3,500, you received 3,000. The value code 44 is reported with what you expected versus what you received. Sorry, that was my fault. The value code 12 in this case would be reported with the 3,000 and the value code 44 with the 3,500, which is where the $500 applied to deductible comes in. Okay. Hopefully that makes sense that I explained that correctly. Sorry, I got it backwards at first. All right. One of the other things that was asked is in this type of situation, what is the patient codes? And the patient code is 101 themselves. Now, these are reported to indicate who has the primary insurance. Okay. So one is a spouse, 18 is self. And the difference is who carries the insurance. So whether it's a wife or a husband or a same-sex marriage, whatever, who is your spouse, that's the primary. This is actually the most commonly seen type of insurance. 18 is second, and this makes sense. Someone asked about 19 and when could you be on your child's insurance, and the answer is if they have the legal obligation to pay for you for some reason, then you would be on a child's insurance. 20 is an employee, 21 an unknown, which you don't really know any of these other ones. 53 would be a life partner. So they're not actually married. They're not a spouse, but it is someone whose insurance you're on based on a life partnership. And then you've got G8, other relationship. So what comes to mind with this one is guardianship. You're not a parent. It's not a situation like that. It's not a child, kind of nothing like that. You're not a life partnership, but you do have legal guardianship of a child who has a disability. That child who has a disability, it is eligible for Medicare. That's an other relationship. It doesn't fit into any of these. And that's the one that really does come to mind that we do see a bit more frequently than others. Okay. But again, it could be any other type of relationship. That's just the example that I have. So hopefully that does answer your question on that. One of the other questions that we get is it's an adjustment amount, but why bill the amount was not paid in full by the primary? Tell us what happened, and we can actually give you the segments on the 835 electronic and where we're expecting that to be. So it could be this is the approved amount or the allowed amount, depending on what they're doing. It could be a deductible amount, a coinsurance, a primary, obligated to accept his payment in full, contractual obligation, legal obligation. So there's just a variety of different things that can happen with this. It really does explain why the primary did what they did. A lot of times what you're going to see this under is the primary insurance's remittance advice, whatever they want to call that. And then on the remittance advice, it'll tell you this is what's going on with it. That's where you're going to get this from. Why didn't they pay the full amount, whatever it happened to be? So why did they adjust it? All right. Oops, sorry. Line adjudication date. Quite simply, I gave you the loops and the segments and all that stuff so you can put it wherever it needs to be. But I want to make this clear. This is what we're looking for. This is your adjudication, and this is what needs to be there. DPT is a segment of the 234 loop. Okay, then qualifier is 573. Time format qualifier D8, and here's the time format: year, month, day. So hopefully all of that is just clear. It's just an adjudication date. When did the primary do what they did? When did they give you the remit notice? One of the things that's happening with this is that people are not formatting it correctly. They're leaving out the asterisk or the end thing, the end marker. And so by leaving any of that information out, this is causing an RTP, and they're like, but it's there, except it's not formatted correctly. So we can't process it. The system can't read it. Well, if the system can't read it, it doesn't really do you any good, if that makes sense. It's just not going to help you at all. Next is conditional payments. And I will tell you, I have 7 questions on conditional payments. So hopefully this slide will answer all 7 of those questions, but if not, I do need you to put it back into the chat for me. So basic question, what is a conditional payment? A conditional payment is when a non-group health plan did not pay timely, and that gives us a 120-day promptly paid window. Again, it's 120 days. Now, 120 days defaults to the date on the claim. When did you submit it? There's 120 days. That's our default. On the other hand, we could say, well, we have 6 claims. Well, the first one is when we saw them for the accident. We've seen them 5 times for follow-up in our outpatient department. Go back. When did that claim open with the primary insurance? That could be your 120-day starting point. So by the time you get to the 6th claim, the 120 days could completely have passed already, because you already have a trail, expectation, a set play in place. Okay. So what is the conditional payment? It is a payment from Medicare, which is designed to give you revenue while you wait for the other insurance to pay. Now, Medicare does not allow conditional payments commonly on group health plans because the group health plan is a different situation. There are 2 exceptions. One, if there's a mental or inability on the patient's half, or if there's a system type issue, but you can look up those. So with the conditional payment, you want to put a 02 condition code on the claim. That is key. That tells us that, hey, we need this. It's workers' comp related. Okay. Now we get into the next set. Can you tell me which one you want to put on there? And again, I can't tell you that because I'm not sure which one, but it's going to be a 01, 02, 03, or 04. And again, it's just what's going on with that claim. If the insurance does, then you can go with occurrence code 24 and a denial date. Now, what that means is if the insurance does deny it, you would want to make sure that you put the occurrence code 24 on there. It doesn't necessarily mean that you're not pursuing or that something else isn't going on. There's a variety of things that can happen with that claim. So again, let's step back. A conditional payment is a claim that you have filed to a primary payer. It is not an employer group health plan normally, so it's a non-group health plan, which is why it is auto, no fault, etc. Then what you want to do is add in the dates, and you want to wait 120 days. So hopefully I'm getting all of that for you guys. And then you want to code it. So a little bit more on some coding. Could you put the MSP value code on there? Well, yep, you need to put something. The value code is going to have a $0 amount, because that's why you're filing it. They didn't pay you timely, right? And then please indicate in the remarks, no payment received during the 120-day period. That's just a way of telling us that you're actually filing for a conditional payment. You didn't receive the payment. You did file 120 days ago. If someone were to ask for proof, they could get that type of information from you, whatever that happens to be. We, as your claims processor, we don't. That's why we ask you to put that in the remarks code so that we don't have to ask you for proof. We're going to take your word on that. Okay, we're going to take your word on that. I will tell you, sometimes not having that there, though, can cause an RTP, because we're like, did you file this 120 days ago? Do we need to ask for it? It's just better to put it there. On line A, put primary payer code C with the primary payer's name. On line B, put the payer code Z with Medicare. That's just a way of saying, hey, this is who should have paid, this is who didn't, and Medicare, so therefore Medicare is responsible. All right. We always have this question come in, and today was no different. What's the difference between billing the secondary when the primary puts it towards deductible or when the primary actually pays? The primary putting it towards deductible is what is called a zero pay claim. So no payments made on the claim. All Medicare, all money is applied to deductible or coinsurance. So the primary didn't pay, but it's because of deductible and coinsurance. Use the appropriate value code with zero. Then use the appropriate remarks reason codes and note in the remarks field indicating the payment applied to deductible or coinsurance, what's happening that nothing was paid, why it was a zero. It's really important to put that in the remarks field so we do have a better understanding of what's going on. So hopefully that all makes sense to everybody as we kind of filter down through that. What I would like to do is the patient responsibility is just walk through some different questions. Sorry. Patient responsibility. Answer this question first, and then we'll walk through a bunch. How do you determine the patient responsibility? Basically, the patient responsibility is to say, add what you've received from the primary and what you've received from Medicare. You'll get a dollar amount. Then take the Medicare allowed amount and subtract what you've already received. Okay, so you should have some amount there. If this equals zero, then the patient doesn't owe you anything. If there's a negative amount, then you've already received more than what Medicare would have paid. The patient doesn't owe anything. If there's a difference and the patient owes you something, that's what we're looking for there. So hopefully that does make sense. All right, let's keep going on. The next set of question and answers is actually the pre-submitted questions. I just didn't have them in anywhere else with the slides, so we'll just keep going with them and then we'll come back. So question number one, what are the most common errors when billing Medicare secondary payer claim? What we actually did is went out and looked this up in the system and we said, okay, what's happening with that? And the interesting thing is that it is that the patient has these working age disability or end stage renal disease, and it actually gives you the number of line items affected on UB04 that is billed. And it tells me how many line items were then denied, and it is working age disability and end stage renal disease, and there's the actual numbers. So that's why we do this type of class, okay? So it's that they have them, but we don't have the information to process them. In other words, it's not on the claim, okay? That's the most common billing error. How do I bill for a claim when the primary did not pay timely? Remember that you still have to bill within the 1 year calendar year limit for the date of service or from the date of discharge. That doesn't change. What you can do is bill it and let it deny and then work with us later. What you could also do is bill for conditional payment, should it fall into one of those situations, and then the primary insurance, whoever that happens to be, will pay it back should that happen. Otherwise, you'll just be able to keep it when that is all finalized. So it still needs to be billed. You still need to make sure it's in the system. You would bill it with a zero pay claim, just saying, hey, this wasn't paid by the primary. We know that. We don't have anything to offer here. And it'll come back as a denial. How do we keep an MSP claim from denying multiple times when entering in DDE? I'm not really sure what's causing it to deny multiple times. So that you keep entering the same claim? Is it the same information? Is it hitting an edit or an audit that should be corrected? I don't know. Is it hitting a duplicate edit? There's so many questions with this one because when you follow through, you want to make sure you're giving all the coding information that we gave up above. But the problem is I don't have a good answer because I don't know what it's denying for. If you do have a claim number, you will want to contact customer service. That's part of what they need to do. You can write into them with a claim number. You can write into them with any PHI or PII, and they'll take that. If you call them, you can get the basic point started. So I'm not sure how to help you with this one, only because I don't know what kind of edit it's hitting. I don't know what's going on with that claim. The next one, why are claims starting to reject with a CO16? I also want to note that this person is a 1500 biller and an 837P biller, which again, this class is not designed for. So take your claim number and contact customer service. I'm sure there's a logical reason that it is rejecting this, only this is not the class for that to be answered. All right. How do I bill a Method 2 MSP claim for critical access hospital? If it's a Method 2 claim and you're billing on the UB04, follow all the information given. If it's a Method 2 claim and you're billing on the 1500, then follow the 1500 instructions that'll come out next month. Again, this is not about a 1500. It was advertised for UB04 837Is. All right. If we don't have anything else, I will jump back and maybe give a couple answers to those two that I kept referring out. But I want to make sure that everyone is given the opportunity to ask questions on the UB04 or the 837I before we jump to the other ones. So Karen, do we have any questions in the chat?
Tom, we have had a couple questions come in. So it kind of pertains to what you were talking about with critical access hospitals and Method 2. One of the attendees said that when they bill the primary charges, they're billing on a 1500. Since they are a Method 2 and a CA hospital, should they be billing charges on a UB04?
We really can't answer that for you, and I'll tell you why. Method 2 has the option to bill on the 1500 or the UB04 for certain professional charges. And it also depends, what is going on. So I wish I could answer that, but Method 2, you really do have the option to do one or the other. And so you'll have to go back and research that out. It's not really about MSP though. It's really about general billing Method 2, and I don't know that off the top of my head, but I do know that there are times when, yes, Method 2 can bill on the UB, but I also know Method 2 can also be billed on a 1500. It's not right or wrong as long as you're enrolled correctly.
Okay, that's all we have at this time.
Okay, so a couple of things. Again, let me show you what you're going to do. If you want more information, I really do recommend come out to our YouTube channel. This is WPS Government Services Medicare. Okay, go to our playlist. Sorry, it's not, there we go. On the playlist, you've got a variety of different playlists. Feel free to look up whichever one you want. The Medicare, actually, we're going to take the word Medicare off and we're going to search secondary. Now, the reason that I like secondary sometimes better is it brings up what I'm looking for a lot easier. But you can see we have videos here, and this is the entire playlist, which I do recommend. The playlist actually goes through all of the different types. So it'll go through like where to contact is going to give you resources. It's going to give you a variety of different items, getting started with MSP. So a lot of the things that we kind of skipped over because it's really in depth, I would recommend taking a look at this, okay? Now, the YouTube channel is great just in general. If you're just looking for something in general, I will recommend that too. But the playlist, I think, is just a really good place to get your questions started answering. Don't forget to look at both the CMS and the WPS website. One of the resources that is a big one, big one for the CMS website, oops, sorry, I had a class earlier today and that's my file from that, is to go under cms.gov, go to Medicare, go ahead and look through all of this, but scroll down. You see this coordination of benefits and recovery. We get this all the time, and the question is, how do I find contact information for them? If you go to Medicare Benefit Coordination and Recovery, now it sounds very weird, but this is where the Medicare Secondary Payer information is located. Click Overview. Here's the Medicare Secondary Payer information, but I do want to scroll down because this is where your contacts list is. And your contact list is great because it does give you the place that you go to for getting things updated, getting set aside amounts, any of that type of information. It's just really good. Also, it's going to give you the Benefit Coordination and Recovery Center, or BCRC. And the reason that they're so important is because they are the ones that actually update the record. Oh, you know what? Let's go down. I'm sorry, I do have a couple of more questions that were pre-submitted. So one, When it comes to billing for FIS, someone asked if they can go in and update the MSP record and in DDE. Now, DDE is what's called direct data entry, and it is a feed that goes directly into FIS, and you can update your claim information. So if you forgot something and you're billing something and at RTPs and you needed to put a condition code or something like that on there, you can do that in DDE. What you cannot do is update the Medicare Secondary Payer record. Medicare Secondary Payer is actually done through a controlled contact center, and that's the Benefit Coordination and Recovery Center. What this controlled contact center does is takes information and updates the record. What they do is they put it into the coordination of benefits system, which then feeds to the common working file, which feeds to the claims processing systems. So the common working file is basically a big, huge communication storage, information storage file. And it's like a hub, I guess. Everything feeds to it. If the common working file is not accurate, so it says something is primary and it's not, that's what stops a claim from processing. It doesn't matter which system you're trying to get it processing through, it just won't do it. So again, you want to make sure you go back to this Benefit Coordination and Recovery Center. I know someone asked me for that contact information and I forgot. So that's where that is at. Along with that, there was a same person asked a question about how can they, which I'm going to assume you represent a provider in this case, how can they update the record? And the answer is you cannot update the record unless the patient has passed away, and then one provider one time can update the record. That's a phone call. You're going to call this number. They'll get that done. If that is not the case, then you must have information on letterhead or on something from the primary insurance, which states when it became effective, which is the coverage, and when that coverage terminated. That's how you can update the record. You send that in, and then the Benefit Coordination and Recovery Center can update that record. If you do not have that, you can send a claim to that primary insurance, get a zero pay claim for them, bill it. We gave you instructions for how to do that. So you're going to bill that saying, hey, it's not covered. It's not part of their whatever benefit package, whatever the situation is. It's outside their coverage. We'll process that one claim. It's not going to update the record. It's just going to update that one claim. Ultimately, it's the patient's responsibility to update the record. Please don't hate me for saying that, but that's whose responsibility it is. Though, if it's an employer-based plan, they could do it. A spouse could do it if it's their plan. So there's a variety of people that can. Unfortunately, years ago, there was a change to Medicare that said that providers cannot, because too many providers would call in, override it, which would mean update it to say, hey, they don't have insurance, click, 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 done. We would pay a claim. Another provider would call in and say, no, they do have this insurance, click, 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 added, and we would take all those money back and open up all those. So what Medicare has said now is, hey, if you're a provider, you do want to make sure that you're following that information correctly. So I want to make that very clear that that's how it's done. And again, you have to go through and make sure you do all of this. Karen, did we get any questions in the chat while I talk there for a moment?
No, Tom, we haven't gotten any additional questions.
Okay, so one other question that I have, and I kind of skipped it because they asked for a bit more information on a review of MSP. What they're looking for is how to indicate or how to know when the patient has an MSP and what are the best resources to do that. And so let me just provide you with a couple of different resources here to kind of help you look that up. First, on our website, it's wpsgha.com. You will see this login section. Now, Karen may need to jump in and help me out here. She's much more familiar with this section than I am, but here's what I do know. You have to have a unique username and password, and that's per person. It's not per anything else. You have to be granted access to a provider's NPI. So if you work for one and there's someone that grants you access, okay. Once you do that, if you go in, and I'm going to use the portal user manual as an example. If we scroll down, again, there's lots of stuff in here, lots of practice information. You're looking for where it says patient and eligibility check. When we get into the eligibility check section, you do want to scroll down, and it'll tell you how to complete the eligibility check. And then as we scroll a bit further down, you'll come to two different buttons. First, under eligibility is where you'll find the primary payer. Supplemental insurance is stuff that is secondary or follows Medicare. So primary, secondary. Keep scrolling down and you'll see a list in the eligibility once you do the full eligibility check, and it looks like this. And you'll see the first grayed out box right here in the second row. It says Medicare Secondary Payer. And if you scroll down on this, I'm just going to scroll down, look away if you don't like that fast scroll. It will indicate to you what is in the Medicare Secondary Payer tab. And there it is, enrollment and termination dates, insurer IDs, all that stuff. One question that came up along with this is, I don't know who that is. In terms of an insurance name and address, keep in mind, sometimes it's a legal name where you may know them as a doing business as name. So you might have to go back and forth a little bit there, but hopefully this will give you what you need. I'm going to stop here. Karen, did I miss anything that's like important to go over during that little chunk right there?
Nope, you got that right, Tom. That's where they go.
Okay, perfect. So if you can't get it from here or you want a direct source, now this is directly fed to us every time you click on the eligibility search. It's fed through a 270, 271 HIPAA electronic transaction. You can actually come out to CMS and search HETS, HIPAA Eligibility Transaction System, HETS. You can access HETS through the 270, 271 transaction directly. You can see it's right here, kind of information on it. So if you'd rather not use our system and you'd rather use this system with a trading partner, that's all great. You can do that. I will let you know that our system's free. This one's not always, because you do have to use a trading partner. So that's the questions that I actually did have. Except someone mentioned that it used to be on the IVR. You are correct. It was on the IVR, but that's been gone, I want to say, since January. The eligibility transaction was something that CMS has shut off for now. What they're testing is to try to get you to use some of the other sources. It's a fraud and abuse prevention item that they shut off. And again, it is a pilot. They aren't sure if they're turning it back on. We won't know that until they make that decision later on. But later on, we don't know when that's going to be. So hopefully that helps everybody. Karen, again, any questions?
We do have one question, Tom. Do you have any information on condition code 08? I'm sorry, is when the beneficiary will not provide information concerning other insurance coverage?
Well, it's exactly what it sounds like. You put condition code 08 to say, hey, we don't even know what the patient wants from us. We don't know what they want in terms of that. The best way I like to do with condition code, and I did not include it, and I do apologize for that, is I like to do, except I didn't type code correctly. This is actually really good information. It is from Novitas or from other contractors. We do have some on our website, but it is a billing. It does kind of walk through everything. It does trigger the common working file. I'm sorry, common working file? No, coordination of benefits to investigate whether there is something on file or what is going on with it. I will tell you, it's not something that's going to allow us to pay the claim, if that makes sense. Like, we can't pay it without that information. It's not that you can't append it, okay? What this will do, though, is make it process. This is important. This is the one that I was looking for. Ooh. It's an MSP fact sheet, MSP booklet. And if you put, I couldn't remember the name of the booklet. I'm sorry, y'all. It'll tell you, okay, for an accident other than, it'll say for Part A claims use condition code 08 to prevent the claim from returning to provider. The claim should reject and assign to patient responsibility, because they didn't give you the information, right? It's not there. So you want to put this on saying the patient's not giving us what they need. It does trigger the Benefit Coordination and Recovery Center to look at it further, or whatever you want to say there. And it is in the Medicare Secondary Payer Information Guide if you are interested in that. If you want to know how to find that, let me think that one through. I think it's CMS, Training and Education is the tab, MLN, probably Resources and Training, Publication. Again, I don't like to use the word Medicare. I do typically use the word secondary. And then I click on the booklet. You just type, not 05, 08. Geez, I'm doing really good today. It'll help walk you through all the different, and it's not in this one. But that is still the correct use. It's just one of the older ones. Yeah, they took it out of here, it looks like. But that is still the correct use. So that's how we always find it is I'm a little bit reliant, I guess, on that older one. But it does kind of tell you a little bit about that. So I don't know if I got enough information for whoever asked the question. So if not, put that back in chat quick and then I'll get you some more. Okay, not hearing anything. Do we have any other questions, Karen?
I don't have anything else coming through, Tom.
Okay, a couple of things to be aware of with this class. You will be getting a certificate. The certificate does come via email should you have supplied your email address. So again, here's your certificate and it's going to look like this. This is the actual email and I want you to notice the certificate's on the bottom. It does come with one contact hour. Governing bodies decide to take that contact hour or not and recognize that for continuing education units. That's not something that we actually do. So we don't issue continuing education units. We only issue contact hours. Okay? But that'll come out really shortly hereafter. Also, it's going to give you a link to complete the survey. Should you want to do that, we'll talk more about the survey in just a couple of minutes here. If you have follow-up questions, and this includes someone who called in who cannot get the survey because they didn't supply an email. If you have follow-up questions, please email us. Email is supplied here. It's wpsghaeducation@wpsic.com. In the subject line where it says today's subject, MSP FIS claim, MSP FIS claim, something like that is good. Please don't be the person that puts today's subject. It is not in quotes, therefore that's not the exact verbiage. We do want what the subject of the webinar is. If you are asking for a certificate, please incorporate the fact that you did dial in. Here's your phone number with area code. Once we get that phone number with area code, we will verify you're on our list of people that attended. And then what we'll do is send out a certificate to you directly. So please make sure that you say certificate, give us the full 10-digit phone number so that we have everything we need right away. Surveys. Please take time to complete the survey for this course. This survey does help us look at what we did well, what we need to change, all of those types of things. You've already seen one opportunity to take the survey, and that's in the follow-up email. Second opportunity occurred right now as Karen probably just stuck that in chat, so you want to make sure you're aware of that. Another opportunity is going to be on the close of the webinar. You'll be given the survey here, and this will give you the opportunity to provide feedback. And we want so much that we're going to give it to you in the encore as well. And this is what it's going to look like in encore. So lots of opportunities to give us feedback. We just really want to hear what you have to say. On this one, for me in particular, I always like people to tell me what I did well, WPS what we do well. So what do you think of us as a claims processor? There will be a question on that. Then tell me what you think I could have done better. What didn't I do well? What did you want more of? What did you expect? Last, tell me if my PowerPoint was good. I call it the good, the bad, and the ugly. The ugly is the PowerPoint. Now I have no control over what the websites look like. We had someone on my last class comment and say, this website doesn't really help me. It doesn't look good. It's not visually appealing. Unfortunately, I don't control the CMS website, don't control any of the websites, so that's not going to help. But the PowerPoint I can. So tell me the good, the bad, and the ugly. All right. I just want to remind everybody that we do listen to you guys. We do hear you guys. A couple of things we've done. Implemented chapters in the YouTube channel. If you're not familiar with that, when you come into any video, we now have chapters listed across the bottom. It's able to help you quickly move through. We did indicate training indicators in all of our advertising for our different trainings. For those of you that are not aware, we do now offer a Medicare Education Expo. Right now on averaging about quarterly. The Medicare Education Expo is a way for you to come to an all-day variety of sessions. The one that is coming up, let me look it up because I don't remember the date on it. I apologize. Let's go back out here. Training Center, and again, I apologize for not remembering this date. 1016, you can see it's labeled part 1, part 2, part 3, part 4, and then 1021 is part 7. This is a follow-up question and answer. This is just a Medicare Education Expo, and if you want to learn more about each one of these sessions, select any of the times. It'll take you to a quick advertisement where you can read a little bit about all of them and then go to register for any of them. The Medicare Education Expos, again, are topic specific. They're driven off one thing. The one coming up on October 16th and then on the 21st, the follow-up question. It's the life of a claim. What do we do with our claims? Just something to keep in mind, opportunity to take out there for education. But that is based on your feedback and what you've done. And we do change the topics based on the feedback that you're asking for during the surveys and other things. Okay. That's it. That's all I have for you. I want to thank everybody for attending. Hopefully you got something out of this. On behalf of myself and Karen, we hope that you have a great day and that you'll attend with us in the future. Please don't forget to take that survey. It is important to us. Thanks, everybody. You may now disconnect.